Okay, let's start out with the earliest. We've got a case from 3/16/17. And we have a history, an 18-year-old man with left knee constant aching and throbbing, catching sensation while climbing steps, occasional sharp pain, prior basketball injury 1 year ago. So let's start scrolling. I recommend you hit 3 up. That way you'll get some size. So you hit the number 3 on your keyboard. And I'll take the first 3 that comes up in the interest of time. And that's usually what I do when I'm in practice. I'll take whatever they've given me just so I can be speedy. Now, if I have a more specific history, I may dive into one projection or the other. And in this case, with this history of knee aching and catching in an 18-year-old, I'm very interested in the patella. I'm interested in the shape and its relationship to the trochlea, which is right here, which looks actually pretty darn good. But patellofemoral dysplasia or trochlear dysplasia occurs in about 1/3 of all individuals. So it is extremely common. You should be on the lookout for it. This is a pretty good one. Now, in an 18-year-old, if you're reading a meniscus tear in a child, what's a child? A child is anyone younger than me. But if they're under 18, you better be right. I mean, you better be right. Because if you cause even the smallest amount of meniscectomy unnecessarily in a child, you change their life forever. It's a big deal. So let's keep looking. We've got some signal in the posteromedial meniscus. The patient has throbbing, aching, catching, pain when climbing steps. You know what that means to me? Patellofemoral maltracking. It doesn't mean meniscus tear. Meniscus tear, trauma, locking, posteromedial pain. This is a maltracker. And how many kids are maltrackers? 50%. Remember when you were a kid and your knees hurt? It happened to all of us, right? When we were growing? Look at this dirty bird. Look at the dirty fat behind the patella. That's friction. That's shearing. That's what happens when there's not congruent growth between the femur and the patella, and when there's asymmetric development of the medial and lateral muscle groups. That's what this child has. Not this signal, which, if we blow it up, is in the outer third. It fades as we go into the inner third. It's window framed around the outside, all by meniscal tissue. It doesn't go up and down, so it doesn't go this way or this way. It doesn't have verticality. Yes, it communicates out here with the capsule, but it doesn't communicate with this articular surface or that articular surface or that articular surface. It's window framed. It's only bright in the outer part. It frequently is either linear or sometimes it'll make a little lazy Y on its side, like a cattle brand. That is normal vascularity of the meniscus of a child. You call that a tear? Disaster. Total disaster. Let's look at the next one. Same child, kept having MRIs. Let's look at the next one. Call it up. Kid had 3 MRIs for the same thing. Yep, there's an effusion. Sure, there's an effusion. He's got patellofemoral maltracking, but it's a small effusion. Did the meniscus change? Not at all. Let's look at the next one. Meniscus change? Let's check it out. We're in February. Let's make sure we're on the right date. We are. Did the meniscus change? Not at all. Let's blow it up. It's the same. They kept chasing it and chasing it and chasing it. This may be the most important case in the whole course. Save the whales. Save the menisci. If you do that and nothing else, in your entire career in MSK, it's the most important thing you'll ever do. What are the key things that tip me off to the diagnosis of patellofemoral maltracking? First, all children have some degree of patellofemoral maltracking, whether it's symptomatic or asymptomatic because they're growing. So I know that's a very common diagnosis. Second, I have no other explanation. Third, I have induration of the retro, supra, and infrapatellar fat pad. Fourth, it's a kid. Fifth, I have a small unexplained effusion. That pattern at ProScan all day long, 20 a day. Does that answer your question? It's a good question, an important question. History is left knee, moderate dull pain for 3 weeks, status post-injury, difficulty bending with swelling and locking. I'm going to try and make them as big as I can. I'm putting up the first three that I'm shown. I've got a coronal gradient echo known as adage. It's an additive gradient echo sequence, also known as MFFE if you're a Philips user, MEDIC if you're a Siemens user, and MERGE if you're a GE user. Very powerful meniscal sequence. Use it if you've got it. You can scan 3D or 2D with it. This time the meniscus looks a lot different. It's also a 43-year-old. There is involvement of the inner third. There's also some truncation of the free edge of the meniscus. Let's make that even a little bigger right there. So that could be one of two things. Either capsulosynovial thickening, so-called flounce, that's pushing the meniscus in, so the meniscus is kind of wavy like a piece of paper, and if something pushes along its free edge, it'll crinkle, and the fluid will replace it. That's what flounce is. Now, it is said that people with flounce are more likely to have a hypermobile meniscus and at higher risk for meniscal displacement, even into the notch of the knee or peripherally more commonly. So flounce may have some clinical connotation. So that's either radial fraying or flounce. There's some chondromalacia here, cartilage too thin, it dips down, it comes out, it dips out again. That's all chondromalacia. And then there's no cartilage. Cartilage, no cartilage. Training your eye. This time the inner third is involved. Our lesion is thicker. It's brighter. It's badder. It's bigger. It's got a cyst like the end of a thermometer. It's got a cyst in the meniscus. It's got a parameniscal pseudocyst out of the meniscus. Why is it a pseudocyst? Because it's not lined by epithelium. So it's a parameniscal pseudocyst of meniscal origin. If you give it to a pathologist, they'll call it a ganglion. It's the exact same thing, except the ganglion arises from the capsule or the sheath of a tendon, and a parameniscal pseudocyst arises from diffusion through the meniscus. Pathologically, they are identical. But it's an important distinction. Cut out a ganglion, you do it from the outside in. Meniscal pseudocysts, you always go from the inside out, unless they're really big, and then you may go from the inside out and from the outside in to shut them off. But if you fix the tear, usually the pseudocyst will dry up and go away. A couple of take-home points about pseudocysts. The medial ones, bigger. They migrate. They're more painless. They like to go posterior. The lateral ones, more painful, smaller. They're often anterior. They're more common. They migrate less. Let's go to the last sequence on here. I think actually we have it up already. No, I think this case is baked. The patient has an effusion. Let's just blow up the axial and have a look at it for giggles and see if there's patellofemoral disease, as there is with almost everyone. And there is a little bit of swelling or blistering of the medial patellar facet. In other words, it's a little brighter than the rest of the cartilage. Now, sometimes that can happen from something called magic angle effect or anisotropic phenomenon, but that wouldn't make the cartilage puffy like that. Yes, there's a plica present, but everybody has a plica. That's an embryologic reflection. That's normal. Large, trizonal, flap tear from anterior body to posterior root, consistent with a trizonal medial meniscus and likely unstable tear with intra and parameniscal pseudocyst formation of X by X size along the posterior margin of the joint capsule is how you would read it. Number 2, adjacent chondromalacia, and then I'd leave the patellofemoral discussion in the body of the report. Now, how do you know how big this tear is? You could measure it. You could do something like this and take lots of time making the measurement, which I used to do. And if you measured all your meniscus tears, you're probably going to be out of a job because you're not going to be able to get through too many cases in a day. But let's say the tear was like this, and you wanted to measure it. Well, the sagittal would be tangent, so you just measure that, and then you'd start adding slices. So add 3 millimeters, add 3 millimeters, add 3 millimeters, and that was, let's say, a centimeter. So you go a centimeter plus 3 plus 3 plus 3, and you come up with a measurement. Or you could do something a lot more simple. You could say, I know that the meniscus is 6 centimeters. 2, 2, and 2. 2 in the body, 2 in the anterior horn, 2 in the posterior horn. So if it goes from here to here, it's approximately 2 centimeters. If it goes from here to here, it's approximately 4 centimeters. If it goes all the way around, 6 centimeters. And that's how I do it. So this one is going to be about 4 to 5 centimeters. Okay, so I'm off, a centimeter. Who cares? Why did I say it was unstable? Because the meniscal height is slightly decreased, and it's a very large tear. Measuring the size of the tear is going to affect the management. Absolutely, it will affect the management. Smaller tears, even tears that are in the middle and inner third, if they're small, we now are more conservative about resecting them. Because we know that once we resect meniscus, the patient's going to develop arthritis no matter what. No matter what, within 3 months. So if you can leave that meniscus in and it scars and it granulates, I know the surgeons used to say, well, you can't leave it in. It's going to cause chondromalacia. Baloney. That is now baloney. If it's causing locking, if the patients live with it for a year and a half and they got clicking, some other annoying symptom, fine. But for small tears, 5 millimeters, 7 millimeter tears, stable tears. Now, there are exceptions to that. Radial tears, they may be more aggressive about trimming those. But smaller flap tears, small cleavage tears, for sure. Small cleavage tears, they're not going to mess with. Even big cleavage tears, they don't mess with because all you can do is resect them. So it does matter. "81-year-old, left knee, moderate to sharp pain for 5 months with swelling and weakness." So we're on the meniscal section. I'm going to put up what they gave me first, real quick. So that's what I would do if I was at home. And I'm going to scroll them very quickly, the axial scroll quickly. I've got a PD on the left. I've got a gradient on the right. Okay, there's a little change in the proteoglycan milieu here. There's some dark signal within the confines of the cartilage, but that's not why we're here. We do have an anterior fusion. We've got a misshapen patella. There's a spur over here. There's a spur off the odd patellar facet. There's a lot to talk about regarding the patella. There's proteoglycan milieu change in the trochlea. Okay, let's move on. Let's move to the menisci, because we're in the meniscal section. What's happening? Why is the tibia edematous? It's not going to be edematous on the gradient echo image because gradient echo imaging is terrible for looking at the bone marrow. It's just not good at it. It's good for looking at cartilage. If I blow my knee up, well, look at that cartilage. It's beautiful. And there's a little bit of change in the superficial proteoglycan milieu here, maybe a little chondrocalcinosis. Okay, let's move on. Let's demystify or demagnify this image and get up another coronal. Let's get them nice and big and bright. Got a lot going on here. We've got the two church steeples of the tibial spine. They're being tugged on by the ACL. They're hypertrophic. They're spurred. As the knee wiggles back and forth, the femur relative to the tibia, they pile drive the poor ACL. And the ACL becomes a little swollen. And the knee notch is a little small. But we're here to talk about the meniscus. Now let's look at both menisci. At first glance, the medial meniscus anteriorly looks fine. The body doesn't look normal because it's out a little bit. Remember, patient is lying down. They're not standing up, and the meniscus isn't even really supporting the femorotibial articulation. That's why they have chondromalacia. Let's keep going, shall we? In the back, the signal starts to bloom. Well, bloom is the wrong word. Get bigger. And why is it getting bigger? Because there's a tear. Now you might say, well, but I don't see the communication of this tear with the inner free edge of the tip of the meniscus. I don't see it going up towards the articular surface, like this. I don't see it going up, I don't see it going down. Okay. So why is the meniscus being spit out? Well, because the patient has a root tear right there. There's a meniscus root, and there's also a root ligament. There's the root ligament. It's intact, but the root is torn. So with loss of the tether, now the meniscus is squishing out. And because it's getting slammed from top to bottom, when you walk, it's developing a large closed cleavage meniscal tear. What do you do about that? Nothing surgical. Nothing good surgical is going to come of resecting that. Nothing good surgical in an 81-year-old is going to come of repairing a root tear. And why do we have edema in the proximal tibia? No support. We got some chondromalacia and no meniscal support. So the femur just banging down on the flat, hard surface of the tibia, causing a subcortical insufficiency, microtrabecular fracture. And there it is. There is the microtrabecular fracture, the line. And there's the edema. That's why the patient's complaining. Oh, we're not done yet, though. Look at that lateral meniscus. It's a hot mess. It's a disaster. It, too, is extruded. And it also has some signal, cleavage-type signal, which we frequently see in elderly individuals. And this time, it does communicate, as they often do in the mid-coronal plane in elderly individuals, in the body. Cleavage tears, like the body of elderly people, all day long. You're going to see this all day long. You don't resect it. You resect it, they're going to get a total knee sooner. Want to hold that off as long as we can. There is chondromalacia. So medial compartment, early failure. Meniscal extrusion due to a tear of the medial meniscus root with a large closed posterior horn cleavage tear, 2 centimeters in length. Number 2, lateral meniscus, osteoarthritis with lateral meniscal extrusion and a body chronic, you can say degenerative if you want, if it's not a workman's comp case, cleavage tear. Number next, knot stenosis and hypertrophic tibial spines. Number next, class 2 to 3 mediofemotibial chondromalacia with femorotibial shift and conformity change. Notice the difference in width between the medial condyle and the lateral condyle. Lateral condyle almost twice as wide. An element of either remodeling or dysplasia. Question is, can I comment on the patellar tendon and the subcutaneous tissues in this region? Are they normal? And the answer is they are not normal. Now, why didn't I comment on them? Did I see them? Yes. Because there are so many findings in all these cases that if I sat here and did every finding, we never get through the cases. But since you asked the question, and it's an excellent question, let's discuss it briefly. There is quadriceps tendinopathy. Okay, he's 81 years old. Kind of gray smearing with linear signal running through it. Not fat, edema. There's traction enthesopathy. There's a traction spur. There's another traction spur below. Now that, where it angles, is magic angle effect. The prepatellar swelling is real. The prepatellar plate, which is the continuation of the superficial bundle of the quadriceps, which is really the rectus femoris, continues on forward, is attenuated. So that plate is thin. Should be a nice fat structure, but he's 81 years old. So he does have a prepatellar plate problem. He's starting to delaminate the bursa and fascia. It's not a Morel-Lavallée, which, by the way, the answer is true. When you delaminate that area, the bursa, you get Morel-Lavallée syndrome, also in the hip too, another common place. But this is microdelamination, so common in elderly individuals, common in people that kneel. So he has an enthesopathy. He's got a plate problem. I'll take it away so you can see it. And that is a fake. That's magic angle, right where the tendon curves. That's real. That's swollen. That's wide. That is a little baby tear in it. That's swollen. And so you're correct. It's abnormal. The intact root ligament. You can barely see it right here. I admit that it's buried by this tear, but there it is. I'm going to blow it up even a little bigger. I'm going to show you many root ligaments, though. Have no fear. That's it. Now, you might say, well, how do you know that's not torn? Well, you can actually see it, but it would also squiggle up if it was torn. And the lateral one, there's a little piece of the lateral one right there. It's a very common injury, by the way, and we see it a lot in elderly individuals as an incidental finding. It may be one of either the sequela or causes of DJD. People separate their roots, the menisci squiggle out, and now they have no support, and they start to develop chondromalacia, bony remodeling. So that hasn't been well described yet, but you heard it here. 84-year-old, pain, felt a pop while running. All right, so I'm going to throw the axial down real quickly because I always begin with the axial. And I would say, put up a coronal, since we're on the meniscal section, and put up a sagittal, and maybe choose 2 different pulsing sequences so you have some variety. So I've got a PD, a standard PD, which I do not like at all in MSK. I do not like a long TR, long TE, unless it's fat suppressed. I'd much rather have a straight T1. Now over here, I've got a very good PD with spur. So the bones are nice and black. I'm going to have excellent water contrast. So it's like having a free arthrogram, right? It's a joint of fusion. So while you're looking, I'll just talk briefly about the axial. There's medial chondromalacia. There is a large effusion. And I subjectively grade my effusions 1 through 4. And if I see a small amount of fluid that's a little more than a centimeter, trace. What's 1 plus? Less than 2 centimeters of fluid. What's 2 plus? 2 to 4 volumetric cc's of fluid. 3, distension of the whole anterior compartment. 4, distension all the way around the entire joint. So this is at least a 3. So effusion 3 out of 4, or you could say moderate to large effusion, that's fine. Medial chondromalacia. I look at the prepatellar plate. I look at the retinacula, good retinaculum, good doggy, bad doggy. Good doggy, bad doggy. What happened to the lateral retinaculum? It's gone. But it's a meniscal case. But you're not going to get fooled. No, not you. You're not going to hone in on the meniscus and forget to look at everything because you've got the whole case in front of you. So you're going to tap into this very unusual lateral retinaculum VLO, vastus lateralis obliquus problem. But that's not why we're here. At least not right now. We're here to focus on menisci. The patient has swelling behind the femur, most likely due to small rents in the capsule from increased capsular pressure that produce a little leakage. Okay, PCL's good, ACL's good. They're both intact. Lateral meniscus? Oh, I don't mind signal in the lateral meniscus root at all because there's synovial interdigitation here. That's okay. Synovium often interdigitates at the root. But I don't want to see that signal go out to the body. And maybe there is a little signal out in the body, so what am I going to do with that? Incidentally noted, small, delicate, bland-appearing cleavage signal in the anterolateral meniscus of a 62-year-old. Boom. Done with it. I don't care. But this one I care about. It's swollen. The capsule's swollen. The tibia is swollen. The signal is brighter. It gets more robust as you go from the outer third to the inner third. Violation. It must get less conspicuous as you go from the outer third to the inner third. Always. 100%. So that's a tear. That's a complex flap tear. It's truncated right there. So here's what it's doing. So we're back here. So that means we're back in the posterior horn. We had a radial component that truncated the inner third, and then it twisted, and it became more linear. So it went from going like this to going like this. It tilted. And that's what you're seeing here, is the tilt. So radial flap tear, one of the most common types of tears in middle-aged individuals that's symptomatic. Now, what are you going to do with this one? If it's me, icing the heck out of it. Ice, ice, ice. Advil, my stomach doesn't like it, but okay. That'll help. And no running. No pounding activities. Physical therapy. That's the real treatment for this. Now, some people will go in and resect this. And the patient will feel better, for sure, for 90 days. And then at 120 days, their knee's killing them, because now they're developing arthritis. So 10 years ago, 100% of these get resected. Today, less than 50%. What's the right treatment? Not to resect it. Another thing you can do is you can use an unloader brace to open the knee. You can use a heel lift to open the knee. Save the whales, save the menisci, actively inflamed tear, radial flap tear, capsular reaction, effusion. Yes, it's symptomatic, and they have a huge problem over here, ruptured the lateral retinaculum with fluid extravasating out. That's going to go in your conclusion. They've got generalized muscular atrophy. They have a 3+ effusion, and unfortunately, innumerable other findings that we don't have time to discuss, including medial patellofemoral chondromalacia. Is there a flipped fragment at the medial root posteriorly? Let's check it out. Could be. When you say flipped, do you mean flipped? I think you are actually seeing your volume averaging, well, I don't know. There may be. I'd have to study it a little further. I'm not sure if you're actually catching the edge of this bone or if you're actually seeing a flipped fragment, because you got a root right there. You got the meniscus root. So this is the thing you're looking at, right? You know, I'm not sure, because look at the shape of it. It's almost identical to the cortex, and the meniscus isn't small. It's a very good question. So it may be that you're just shaving the back of the cortex, or it could be a flip fragment. I have to be honest with you. I'm not 100% sure. Let's look at the axial, see if that helps us. Because if it was a flip fragment, that would change the management. We might want to extract it. Well, let's leave it at this. I'm not sure. I think it is the back of the cortex, but if it was a flip fragment, we'd have to chase it. Let's see it in the sagittal on the T1. It's the old one-cut rule, There's the bone. It's on one slice, and then it goes away. It would be the world's thinnest flip fragment. So I think it is the cortex. But I wouldn't take a bet on it. Let's continue on, shall we? Great observation. Thank you. That case was read as unstable. So somebody may have dialed into that and thought that was a flap as well. That wasn't my case. But it was read as an unstable, complex, actively inflamed tear. Okay, this is a 55-year-old male, lateral and medial left knee pain for a month. So both sides, going up and down the stairs 60 to 70 times while carrying things. Who does that? You take the elevator, don't you? Not everybody has an elevator. Not in Russia. No elevators in Russia. They drop you down the elevator shaft in Russia. So we have a funny little split in the patellar apex. It's penetrating, right? It goes through the osteochondral plate into the underlying bone. It is delaminating the superficial layer of the cartilage, so that's a nasty little ulcer there. That is going to hurt. Pretty good-looking cartilage, though, for 55. Pretty thick. I also like to look at the trochlear cartilage, which is also pretty thick for 55. Let's move on to the case, the heart of the case. So I'm gonna go 3 up. I'm gonna put up my coronal T1, my coronal additive gradient echo, and my sagittal PD fat sat. That is really all you need. Now, what do I really need? I really need this and this. That's all I really need. The sagittal PD and the coronal T1. I can read 98% of all knees that way with the axial. 3 sequences. And as you get more sophisticated, you'll use fewer and fewer sequences. I'm making mine really big for teaching purposes. I would suggest you not make yours as big so you can see the whole image. So I'm scrolling from the medial meniscus body, and I see some vague, ill-defined linear signal that fades away. Doesn't bother me. Patient's 55. There's no osteoedema. It's gone. I'm feeling good. I'm moving. I'm moving towards the center of the knee. I'm still moving. I'll give you all this swelling back here. I won't give you this swelling. Shouldn't be there. There's swelling of the meniscocapsular reflection. Let's keep going. The meniscus should gradually taper down. It's tapering, and then boom, suddenly, without warning, it disappears. That shouldn't happen. The meniscus becomes a sudden ghost. Where did it go? Well, the root has been wiped out. I see some semblance of root ligaments. Now, what is that? That is a combination of meniscal tissue and root ligaments rolled in a ball. Proven case. So we've got good doggy, bad doggy. Good ligament. Good lateral root ligament. Bad ligament with a gap. Ligament rolled in a ball around a piece of meniscus. Defect. Meniscus tether lost. Meniscus migrating towards the west coast, towards California, towards Perth, towards Lisbon, going west, and the patient isn't even standing up. Not good. And there's cleavage signal throughout. Now let's see if the cleavage signal is worse on the medial side than the lateral side. It is. Is it communicating? It's not, except for here. So describe it as a large meniscal root ligament and root tear with intrameniscal cleavage signal secondary to loss of the meniscal tether and hypermobility. This one is not squishing out the back, but it does have meniscocapsular swelling. Now you have to understand the sequences to understand the signal. For each scanner, you're going to have your most favored nation meniscal sequence, which means it's going to be most sensitive, but also overestimate tears. So you've got to know that. It's going to have the most meniscal signal. And then you're going to have sequences that have less meniscal signal, but high specificity. You're going to have sequences like T2 that have no meniscal signal and are highly unreliable. And you're going to learn on your machine which ones are the best. This one gives a lot of meniscal signal. This one gives a lot, but has higher specificity. Sensitivity, specificity, specificity. But notice, I do not have a T2 fast spin echo that I'm relying on for meniscus. In fact, I don't even have a T2 fast spin echo. I don't need one. I can see the ACLs present. There it is. Totally present. And look at what's happening to my medial root. It's disappeared. My lateral root, not quite normal. Nearly normal. What's abnormal about it? Stretched. That root is stretched, allowing the meniscus to float up. That's what happens when you've been on the earth for 55 years. Things stretch out. Things dry out. Things degenerate. Now, if you didn't comment on that, I wouldn't blame you. But that's a very subtle, high-level finding. How about our PCL? It looks good. Our ACL? It looks good. And I'll skip over the collaterals for now. I don't think they're relevant, even though there's a little bit of swelling. That swelling is secondary to medial compartment arthropathy. MCL swollen, no trauma. You call it secondary inflammation, right? You don't get spontaneous MCL tears. That's silly. You need trauma. Happens all the time, all day long. Capsule and MCL swell due to medial compartment disease. So this patient has many findings, but most importantly, a medial meniscus root and root ligament tear, they're not attached, with intrameniscal cleavage signal, loss of the meniscal tether, medial partial extrusion, and adjacent chondromalacia without active osteoedema. Just for giggles, let's check out the gastrocnemius bursa. There it is. It's slightly dehisced inferiorly. That's common. And the cruciates and collaterals were intact. Let's move on. Complicated, but pretty straightforward. 28-year-old right knee pain. The all-purpose history. How to lose a guy in 10 days. How to get an MRI in 10 days. Knee pain. It was a movie, I think. I had 3 sagittal sequences, so I decided to pull all 3 of them up at the same time. Would I do that if I was by myself? Yeah, I would, because for some reason they got 3 sagittals, and that means something must be going on in the sagittal projection, or they're just silly, and they had nothing better to do than get sagittals. We don't have much of a history. Knee pain. Let's scroll. ACL looks good. PCL looks good. We've eliminated that. Meniscus doesn't look so good. Let's go to the medial meniscus. Looks good. Wow, we figured out what's wrong in 10 seconds. Right? Main problem, 10 seconds. There it is. It's a cleavage or oblique signal, mostly cleavage, and it's associated with a perimeniscal cyst or pseudocyst of meniscal origin. It's got what I call the meniscal arrow or thermometer sign, right? Here's your meniscus. Here's your arrow. Here's the tip of your thermometer. And it comes right out of the middle. right out of the center. If it came out of here, ganglion. Could be a capsular cyst, but often a ganglion pseudocyst, histologically identical. Game over. Now the patient's 28. What are we going to do with that? Well, because there's a perimeniscal cyst, and it's inflamed, and it's inciting soft tissue swelling, they're going to have to deal with it. They're going to have to go in, trim it gently, bovie it, suture it, shut it off. That'll dry up. Game over. Take as little as humanly possible to shut that water spigot off. Now, unfortunately, he's only 28. He's got another serious problem. Now, if he was 88, not serious. 28, serious. Good cartilage, terrible cartilage. No cartilage, no cartilage. And at 28, he's already developing insufficiency-related edema and microtrabecular fractures. Not good. What happened? Must have had an injury. Or he's got severe, persistent microinstability. But more likely a prior injury. Let's look at the medial side. Cartilage thin, thick. Good cartilage, thin cartilage. But normal meniscus and a little bit of swelling posteriorly. Now I'm going to demystify and demagnify this image. It's my water-weighted image. So I use it like a bone scan. Anything bright is going to show up white. So you can be a novice, and you can look at this scan and find the bright spots. Like here. What's going on here? Tib-fib arthrosis and inflammation? Maybe. Popliteus reflection distended with a little bursal cyst dissecting down? Likely. A little bit of fluid in the back. Some varices in the back in a 28-year-old. Not good. Capsular swelling in the back from the effusion. Not good. A bursal cyst in the back in a 28-year-old that's partially dehisced. Not good. And you found it all on one pulsing sequence. Just for fun, let's look at his coronal and his axial. Check out the axial first. Let's see how bad his patella is. It's a T2 axial spin echo, 4 millimeters. Pretty good for superficial cartilage, not very good for deep cartilage, but he's got plenty of cartilage. Patella, other than some spurring for age, normal. Trochlea, not so good. Irregular, penetrating fissure, broad saucerized fissure, problem. But one of his more minor problems, he's also starting to delaminate the prepatellar plate. There are 3 or 4 layers to this plate that we'll learn later on. How about the coronal? Oh, there's our tear. It's a nasty one. All the way from the anterior root to the anterior body horn junction to the body, keeps going, and now it's gone. So do I need to measure it? No, I don't. Anterior horn, a little bit of the body, 3 to 3.5 centimeters, predominantly cleavage tear with perimeniscal pseudocyst formation of meniscal origin with surrounding swelling or actively inflamed, period. Effusion with gastroc bursal cyst, period. And then I go right on down the list. What you want the clinician to know, you put in the conclusion. What you want your other radiologic colleagues to know, you put in the body, so they can't say, oh, you missed that. So you bury it. And you want the conclusion to be concise so the clinician doesn't have to read 10 sentences. In fact, the first thing, number 1, should be the one thing you want the clinician to know. So don't start the report with patellofemoral chondromalacia. That's stupid. Start it with the clinician's need to know information, which is the meniscus. It's an ACL tear. Start with ACL transection. and then go to the second and third and fourth most important findings. Patellofemoral chondromalacia, trochlear chondromalacia, and maltracking. Now, the effusion was related to the meniscus tear. The question is, what was all the swelling in the anterior knee related to? And that's the answer. 38-year-old, chronic anterior and posterior left knee pain, worse in the last 6 months. It's locking. Patient had prior arthroscopy 6 months ago. That's not good. It got treated, and now it's locking. I'm going to go 3 up just for size. I'm going to go right in order this time. Axial, coronal, sagittal. I have an axial T2 without fat suppression. I have a coronal T2 fat suppression. Not one of my favorites. Not sensitive for meniscus at all, but fortunately downwind I have another water-weighted image. I have a T1. So let's start with what they've given us. So he has anterior pain and posterior pain. So I'm going to drill into the patella first. And as a cause of anterior pain, I do not see any penetrating or high-grade chondromalasic lesions. 38-year-old looks like excellent hyaline cartilage. Okay, my ACL looks fine. Well, maybe not. Kind of swollen, actually. Too much tissue there. PCL, present. MCL, present. LCL, present, without swelling. Let's go to the coronal. You could read the whole case off the axial. Let's go to the coronal T2. We've got a glob, a glom, a mass, a cystic mass in the midline. That doesn't speak well for a cystic mass arising from meniscus, not in the midline. Let's go to the sagittal. Look at our ACL. I think it's time to pull down something very water-weighted in the sagittal projection. A big celery stalk, but we can see through all the swelling. There is notch inflammation. There is notch synovitis. If you have cystic change, I will use the term mucoid degeneration. And if you have an actual mass-like cyst, I'll say mucoid degeneration with a cyst or pseudocyst. Why do I say cyst or pseudocyst? Because I don't know if it's lined by epithelium or synovium or not. Kind of a pseudocyclops lesion. Patient hasn't had surgery, but it looks like one big giant eyeball. So why did that happen? Look at his notch. Notch is small. Got notch dysplasia. If you measure the notch in the axial projection, it should be at the level of the ACL insertion, which is either here or here, 2 centimeters. This one tapers in. It is not 2 centimeters. It's 1.3 centimeters. Got notch stenosis. He's only 38. So he has notch impingement syndrome with notch synovitis and a large cyst or pseudocyst as a result. How about the menisci? Let's come back to him. Medial meniscus, I'm going to blow it up. Normal window frame signal outer third, just fine. Lateral meniscus, normal window frame signal laterally. See if there's any other information I can provide you. Not really. A couple of other noteworthy points. Femur lined up pretty well with the tibia. That should sit on the teacup of the medial tibial spine. That should sit on the teacup of the lateral tibial spine, and it does. Although the patient is developing a little chondromalacia, a little reactive edema from the notch synovitis. So we have now just entered the realm of ACL disease. Now, before we leave the meniscus for a minute, just a quick summary, because this patient has normal menisci. So let's look at our meniscus and say goodbye to it only for a little while. Tears of the meniscus. Radial longitudinal tear. Vertical longitudinal tear of varying length. Could be long, could be short. Horizontal cleavage tear. Horizontal. Almost never touch those. Often degenerative. Occasionally traumatic. Almost impossible to fix. And you get variations of these where they're gapped. You want to look at the radial tear and measure its depth. Does it go all the way, the full depth of the meniscus? You want to measure how gapped it is from side to side. Let's keep going. What if we have something like this, where we have a vertical tear that all of a sudden widened into a giant chasm? And then you do a coronal projection, and now you have meniscus, a gap, and meniscus, so that it looks like this in the coronal projection. Piece of meniscus, not connected. And here it's truncated. Bucket handle tear. And the bucket handle tear may fold into the front. It may flip into the middle. It may occasionally fold in the back. The bucket handle tear may detach. Here's what I mean by that. Bucket handle tear may do this. Have a big bucket handle tear, and these pieces never come back together. Detached in the back. It may detach in the front. This detached piece can roll around in here. This detached piece can curl inward. Can do the opposite. The detached piece can twist. There's also something called a folded flap tear, where you have a large flap tear, obliquely oriented, and it just cleaves the meniscus like a cleaving amoeba, and the meniscus folds over on itself. So now you have a meniscus that's a little small, and they have a piece of meniscus on top of it. Or that can twist and fall over and go forward. Those are some of the more common variations of meniscal tears. And then finally, you saw the very common but oft overlooked meniscal root tear, which is usually a radial tear of varying depth. When they go all the way through, or when they're deep, you get loss of the tether. Meniscus starts wiggling side to side. You get cleavage signal internally. The meniscus extrudes out to the side, and eventually the root ligaments themselves may rupture from the force that's put on them. And this will define our entrance into ligaments. Got a lot of images here. I'll put them up in order just for now. The history is a 60-year-old female with acute left knee pain, mostly anterior, exercise injury 1 year ago. That sounds kind of meniscal. Let's scroll coronally. A T2 fat suppression. Don't like that for menisci, but T1 pretty good. Pretty good for menisci. Let's get something a little more meniscal friendly. Another T2. All T2s. All right, we'll have to live with it. But the quality, pretty good. Meniscal tear, no. Nothing. Yeah, everybody has signal. Faint signal, central signal, peripheral signal, wispy signal, cleavage signal. It's all good. Chondromalacia? Sure. More chondromalacia? Sure, but that's not an acute injury, is it? It's not swollen. It's not edematous. There's not an insufficiency fracture. No, that's not the cause of the clinical syndrome going in the body. Class 4, Class 3. How about the collaterals? That could be acute. MCL, fine. Fibular collateral ligament, fine. More to come. Is there swelling around the FCL? No. That gets you off the hook pretty quick. Yes, there's lots of proteoglycan milieu change in the lateral tibia, but that's not acute. The effusion, that may be related to something. That's a pulsation artifact. But there is something swelling that's a little strange. The ACL is swollen. Yet she didn't report a twisting injury. All she reported was acute knee pain. Look how swollen that is. And look how small her notch is. Everything's squished together. You can get dysplasia height-wise. You can get it width-wise. You can get it from spurs and ridges. And it's extremely common and one of the most overlooked diagnoses. Now, one thing I do not like to see is I do not like to see my notch do this. Now, I just need to put the image up. By the way, gastrocnemius semimembranosus bursa, dehisced. That could be her problem. That would give you acute pain. So that's in the running. Now, as I said earlier, one thing I do not like to see is I don't like to see my notch do this. I don't like to see it triangulate as I go deep. Now let's have a look at it in the axial projection. Wow, look at that. Comes to a point. It's got a weird shape to it, doesn't it? If we measured the width, it'd probably be right under 2 centimeters. So the dysplasia isn't really back here. It's more anterior. So she's got notch stenosis with a swollen, strained, inflamed ACL. And I would put in the conclusion that she is also dehisced her gastrocnemius semimembranosus bursa. Let's take a look at it. And those are both potential candidates for her clinical syndrome. Now, if her pain is posterior, I would have said this is number one. But her pain's anterior. And her swelling of her ACL is anterior. So that's number one. Conclusion. Notch dysplasia. Notch stenosis. ACL interstitial swelling and inflammation due to such. Number two, gastrocnemius semimembranosus bursal cyst formation with posterior dehiscence, which is my way of saying, hey, it's not anterior, it's posterior. That's not the one. The question is, why would notch stenosis present at such a later age? And the answer is, she's doing exercises, so maybe she wasn't exercising as vigorously. Maybe she decided to get in shape. At age 60, we all do that, We say 60, okay, now I'm going to lose 14 pounds, and I'm going to go to the gym, and I'm going to do yoga. So maybe she's doing some activities that she wasn't doing before. It's not uncommon. It's kind of a cumulative thing, and it depends on their activity. And that's what makes MSK so unique. So it's an excellent question. Why did it take 60 years to present itself? But that answer that I gave you is a logical and reasonable answer, and often is the answer. They're doing something they didn't do before. And how many times have you seen that? Many. Okay, let's talk about traumatic bone injury. Radiology used to be so easy. You look at an x-ray, fracture, no fracture. Well, in my opinion, reading x-rays is as hard and in some ways harder than reading MRI, because you've got to read indirect signs. Young radiologists today are not good at reading x-rays. They're getting better at reading MRI and worse at reading x-rays. They just don't see enough. Most of you that are above 50 probably read 100, 200 x-rays in a day in residency. Now, some of you out there in training do get that, but it's not as common anymore. And reading these indirect signs of fat pad loss and effacement and swelling and subtle cortical step-offs, sometimes tough. But the old fracture, no fracture doesn't apply anymore. And that even means that the Salter-Harris designation doesn't really work in MRI. because you're going to have a Salter-Harris 1, but you're also going to have a nasty big microtrabecular contusion in the metaphysis or epiphysis. What do you do with that? With a normal X-ray in those areas. Let's start out with signal. I'm going to grade bone injuries 1 through 5. This is just how I do it. 1, low-grade contusion, a bone bruise. Only the most water-sensitive sequences show it. Stir, spur, special, spare. T1's normal. No lines. 2, signals on the T1 and on the water-weighted image. No lines. What's a microtrabecular infraction? Thin, little, less than a millimeter in width. Spidery lines don't go to the cortex and are not associated with any cortical irregularity or step-off. 4, the F word, microtrabecular fracture. It's cortical or subcortical, like the one I showed you, the insufficiency one with the meniscus tear. But it's not fragmented. The lines are still very small and delicate. Fracture. The lines are thicker, 3 millimeters, well-defined, jagged, zigzag, gapped, angled, displaced, but may not be visible on X-ray. You can see fractures a lot more easily on MRI than X-ray. All of these, normal X-ray. These, some normal X-ray. So you have to decide, is it a micro or macro fracture? Growth plate involved. Salter-Harris designation or something close to it. Is it cortical, subcortical, gapped, depressed, displaced, angled? Things you know from regular X-ray evaluation, they apply on MRI. Don't abandon them. Remember that bone injuries are a sign of Lisfranc ligament tears, elbow dislocations, the Osborne collateral lesion, ACL tears, PCL tears. I gave you a whole list. OCDs. What's an OCD? Just got asked that 2 weeks ago. Isn't that an OCD? I said, yeah. I said, well, what does that mean? And they started fumbling around. They said, well, what's an OCD? And I said, well, it's just a defect of the bone in the cartilage. Any defect. It can be a chondromalacic OCD. It can be a fracture OCD. It can be osteochondritis dissecans. It's a descriptive term. It's a defect in the osseous and cartilaginous tissues. So you want to decide what kind of OCD it is, how fresh it is, how unstable it is, what's the depth, is it displaced, is it fissured, is it loose, is it dislodged, has it migrated, is it weight-bearing or non-weight-bearing, does it have broad, wide shoulders, chronic, or acute vertical shoulders, acute, has there been trauma, is there arthritis nearby, is there edema surrounding it? Is the bone deep to it good quality bone that you could anchor pins into? Is there a wide or narrow zone of transition? Here's a diagram showing you the different stages of bone injury: low-grade contusion, high-grade contusion, microtrabecular infraction, microtrabecular fracture, and then fracture. More jagged, cortical communication, irregular, or the stress fracture that looks like atrial fibrillation. Chronic fractures, especially stress or insufficiency fractures more commonly, may be sclerotic. Now, what about fractures and union? The best way to tell if a fracture is unified is CT. Does a much better job than MR, but MR is okay. You're going to look at the cortical union and the medullary union. You want to look at the character and quality of the medullary bone. Is it dense? Is it cystic? If it's cystic, probably not that healthy a bone. What about union? I expect union to be done by 16 weeks. In most patients, bridged in 8 weeks. One of my relatives sustained a serious trauma, and he's a chef. He ate watermelon because it has citrulline in it. He healed a clavicular displaced fracture in 3 weeks. So there's a lot of variability. Young guy. So you can heal him at 3 weeks, you can heal him at 8 weeks, but by 16 weeks, it should be done. What's a non-union? A non-union is when you have high signal at the fracture site with cysts on either side because the bones are moving. What's a malunion or a fibrous malunion? Lower signal intensity, no marginal cysts. There's not as much movement, and there's little to scant high signal on the T2 weighted image. There's a non-union on CT. Here is a partial non-union. So when is it okay for your patient to go out and play Aussie rules football, American football, European football, after they sustained a fracture of a major bone, let's say the scaphoid? When there's 50% bridging. That's the number we use in professional sports. Not on one slice. This is one 1 millimeter slice. You've got to look at all the slices. So it's a volumetric analysis. So not only is it 50% this way, it's also 50% A to P. So if you've got 50% bridging, they can play. All right, this is a complicated one. It'll take a little more time. Big effusion. Nasty looking medial patellar facet. Skiing injury in a 32-year-old. I'm going to try and get some variety here. I've got my axial water-weighted image on the left, showing for a 32-year-old a macerated medial patellar facet. Why do I say macerated? Because these fibers of this portion of the cartilage is just hanging out there. It looks like mush. That's probably an acute byproduct of his recent injury. Yes, there's prepatellar swelling. Let's check out the coronal T1. I picked that so I could have it side by side next to a sagittal PD spur. So our coronal T1, skiing injury, we're interested in the collaterals, the MCL. Injured anteriorly. The superficial MCL known as the crus, the middle layer known as the tibial collateral ligament. It's got another really weird name that I'm not going to give you because it's confusing. And then the deeper layer, which consists of the capsule, the meniscocapsular attachments, and this little nubbin right here called the POL, the posterior oblique ligament of the knee, right there. Well, we've depressed the posterior aspect of the tibia. So what's happened is the femur has translated backwards and slammed down with muscular contraction against the posterior edge of the tibia on both sides. And we don't have a contusion, we have a fracture. A full-blown fracture with a little bit of depression. That's not good. So to evaluate the classic pivot shift injury, with the foot slightly externally rotated and the femur internally rotated, and the patient may take a blow to the side of the knee. I'm going to demonstrate it for you later. Let's see if there's an anterolateral femoral terminal sulcus contusion. There isn't. Be right here. Not. I'm still on the T1 though. I'm going to demystify it a little bit so I can see everything. Fibular collateral ligament, present and accounted for. Well, that's good. Biceps femoris and conjoint tendon combines with the fibular collateral. Its footprint is on the lateral fibula. On the apex, arcuate. Fibellofibular ligament. Popliteofibular ligament, more medial. Conjoint, more lateral. Menisci is still looking pretty good. Well, maybe not so much there, huh? Let's keep going. Our ACL, gone. Haven't gone to the sagittal yet, gone. It should look like a water slide coming down and separating into anteromedial and posterolateral bundles. It's not. It's a mush of blood. The PCL, it's good. It's normal. So what else can we ascertain? Popliteus origin, swollen but present. So I think it's time to look at the corners. Hard to see the corners in the coronal, isn't it? Because you're tangent to the corners. In other words, the back, posterolateral corner, posteromedial corner, and the posterior aspect of the knee. So we already know we have an ACL tear. Here it is, or isn't. Let me give you a T2 just to make it a little easier. Here it isn't. Blow it up. Just blood. Just fibers flopping in the breeze. That view is parallel to the axis of the ACL off the axial projection. Now for the ACL, I like the axial for the femoral end, cleaved right there. I like the coronal for the tibial end, and I like the sagittal for mid-substance. I use all three. We have a fracture, a depressed fracture laterally. Let's check out our stabilizing structures posterolaterally. I think we need a series of sagittals to do that. So not the T2, because that's not all the sagittals. Let's take the T1 together and the PD spur and start scrolling. So what are we interested in? We've already said the fibular collateral, it's intact. The origin of the popliteus right there, it's intact. But what about the popliteofibular ligament? That is a very important stabilizer that is medial in its insertion to the conjoint tendon on the fibular head. And this one is a squiggle. It's like the mermaid with a tail. The mermaid's tail is squiggling. There it is. It's the mermaid sign of popliteofibular ligament posterolateral corner tear. And behind it, what lies behind it? Sounds like a movie. What lies behind it? The arcuate. There are two limbs of the arcuate, a medial limb and a lateral limb. We'll show them to you after the break, but in place of those limbs, a floating linear structure with some swelling. A reet of tissue back there, which is the sheared, torn, capsular condensation of the arcuate. In this case, both limbs are torn. There's a limb of the arcuate. That's the medial limb. Look at it. Stops right there. Arcuate tear. Pop fib ligament tear. What else is relevant in the posterolateral corner? The fascicular attachments of the lateral meniscus. Remember from anatomy, you've got a lateral meniscus, and you have a pop tendon, and you have a popliteus hiatus right here, and you have perforation of that hiatus for fascicular attachments from the lateral meniscus. You have a high attachment, superior and inferior. They even break them down into deep and superficial, or medial and lateral. So you might even configure in your mind that there's 4 condensations. Supromedial, supralateral, infromedial, infralateral. Where's the inferior one? Oh, granted, you have a fracture, so you're going to have blood and edema there, but there it is. Detached, inferior, lateral, meniscus, fascicular detachment, adjacent to the fracture. No big surprise. So we have a posterolateral corner injury. Are we done? No, we're not done. We got to go to the posteromedial corner. Wait a minute, this is MSK. This isn't neuro. We have to look at every cranial nerve. Well, guess what? There's a lot of cranial nerves in the knee. They're just not nerves. Well, our fracture over here is depressed. And we're going to talk about this after the break. But you've got the semimembranosus corner. The semimembranosus is the main stabilizer of the posteromedial corner. So if you lose that, you got big problems. Now, is it normal? No, it's not normal. It is diffusely swollen, and there's swelling around it. It's still attached. Now, the main component of the semimembranosus expansion is the direct arm, and there it is. It is still present. The second most important is this anterior reflected arm, also known as the pars reflexa. There's another arm called the capsular arm. So we see the capsular arm. Sorry, I pointed to that incorrectly. The capsular arm, the reflected arm, the direct arm. So you see three of the arms of the semimembranosus expansion because of the swelling that is present. There's also a distal attachment that's buried right underneath this. We can't see it. And there is a fifth arm known as the inferior distal arm, which you see in the coronal projection. Let's see if we can pull it out. Goes way, way down. You have to go to the back to see it. And there it is. Right there. The inferior arm. So 5 arms of the semimembranosus expansion highlighted by this posteromedial corner sprain. Now, what are the other components of the posteromedial corner? That's just the semimembranosus and its expansions. What are the 2 other relevant areas? Well, they include the meniscocapsular attachments. That one, a little truncated right there. That should be a point. In other words, it should look like this. It doesn't. It's truncated. What comes off there? The POL, the posterior oblique ligament of the knee. That's injured. What about down low? Down low we have a meniscocapsular attachment. Gone. So the break stop mechanism, or part of it, the meniscocapsular reflection, it's gone. The semimembranosus, sprained. Are we there yet? No, we're not there yet. We've got to look at the POL. POL comes off right here. That's the POL. It should attach to that triangular structure. Let's make it bigger. It's exciting. I get excited over this case because you can see everything. POL, not attached to the tip of the meniscus posteriorly. Now, there are 3 components you're going to learn about in the POL. There is a capsular component, a tibial component, and a superficial component. Let's look at them sagittally. The capsular component is this component that's in the back. And it's actually going to cross over superficially. That's all still part of it. And it's going to merge with this tissue right here. So this tissue that's going up and down, that is not the tibial collateral ligament. You're too far back. Let me demagnify it so you can get a feel for it. Make the windowing a little tighter. Straight up and down, going down and sloping backward. That is the capsular arm and the central arm. Capsular arm, central arm, POL. So let me draw over it, because you're going to be able to see it once I draw over it. Division between the POL, P, and the tibial collateral ligament, middle layer of the TCL, middle layer of the MCL, T. Let me take it away. Let me put the line back. And you can even see it, the tear in the POL right there. The tibial collateral, straight up and down. Let's scroll it. Maybe only one cut shows it. Straight up and down. The POL, sloping backwards. The posterior component of that is the central or tibial arm of the POL. The one in the back that you saw was the capsular arm of the POL. Capsular arm, back, tibial arm, less back, and then the central arm in the front. What's the most important one? This one. This is the most important component, and it's got a rip in it right there. So this patient has posterior medial corner with some sparing of the semimembranosus expansion. It's sprained, it's swollen, but nothing's detached. POL tear, meniscocapsular attachment tear that includes the capsular arm of the POL. On the lateral side, we lost the pop fib ligament and the arcuate. We got a posterolateral tear. Are we there yet? No, we're not there yet. I bet you thought we were there yet. There's one more component, the OPL, the oblique popliteal ligament of the posteromedial corner. That connects the lateral side to the medial side. Can we see it normally? No, we can't. And here it is. It's this. It's that structure. Normally we can't see it. It's fused with the capsular layer. And they go together all the way over to the other side. Look at how buckled and swollen it is. That's the OPL. So the OPL goes all the way from medial to lateral. We've got an OPL stretch. We've got a POL tear. We've got a meniscocapsular junction tear without displacement. We've got a posterolateral corner tear. We've got fractures. We've got an ACL transection. We've got an MCL sprain. Game over. Time for a break. Any questions on that one? Brutal. Absolutely brutal. Love it.